Thank you. I'm actually a mentor, but moreover a colleague of Kelly's, and I'm honored to be here. It's the most exciting thing about being a clinical researcher is getting to be inspired by the work of other clinical researchers, and Kelly's inspiration is contagious. Just want to give my disclosures. So I want to start, and I wanted to present tobacco treatment as another unaddressed area of cancer care, but moreover one that is overlooked, particularly in patients with severe mental illness, and give a quick overview of our trial, and due to Kelly's influence, how we were able to overcome that. So our trial was integrating tobacco treatment into cancer care. Is it possible to get the presentation here? No? Okay. So this shows that we've been successful with public health campaign of smoking. Fewer than 1 in 5 folks in the U.S. smoke, particularly Massachusetts. That rate is low. It's been a tremendous public health success, but it hasn't translated to all patients. So these are some diagrams that I pulled out of recent research showing the smoking prevalence. You can see the population-based level, less than 1 in 5, but the smoking prevalence among patients with severe mental illness. This article just came out a couple months ago. It says past research has shown cigarette smoking among individuals with serious mental illness is very common. It's a major factor contributing to premature mortality of patients with severe mental illness, and it's not improving, not among these patients. So this work Eden Evans has done is a psychiatrist here. She's done a national trial. The results came out recently where they enrolled over half of patients with serious mental illness into the trial to assess and determine the efficacy and safety of smoking cessation counseling and medications for these patients. And Eden was really one of the forefront, showing that the majority of patients with SMI indeed do want to quit smoking, and they can benefit from these different medications. And these are the medications we ended up using in our trial. And so the question are, why aren't they offered treatment? So then what happens when patients get diagnosed with cancer? As Arthur just pointed out and depicted wonderfully, they keep smoking. So now they're dealing with their cancer and the difficulties, and also trying to quit smoking. Many cancer patients who smoke want to quit, similar to patients with SMI. Following and during cancer treatment, they're not getting the help that they need, and only half, as of 2009, it was part of our article showed even half of NCI-designated cancer centers didn't offer this treatment. And a treatment program, and it's a very low bar for treatment program. This has been changing, fortunately, over the years. So why? What are the benefits of quitting smoking for people with cancer? Well, it's very simple. Quitting smoking improves your cancer treatment outcomes. There are negative effects of continuing smoking in terms of surgical outcomes, radiation treatment therapy, and in terms of chemotherapy. But it's often an overlooked matter, similar to patients' mental illness, because folks might not be trained in dealing with this, or might be concerned that the patient just needs to focus on their cancer treatment. But no, the patient's mental health and the patient's deleterious health effects like smoking also need to be addressed if we want the best outcomes for our patients. So why doesn't this get addressed in cancer care? So there's 3 factors: patient level, physician level, and systems level. We've done a lot of work in my shop about stigmas. Stigmas against smokers, stigmas unfortunately even elevated among cancer patients who smoke, and also stigma for patients with SMI. So patients with SMI who smoke, and a great percentage of them do when they get cancer, have kind of a perfect storm of stigma. A few years ago, the Surgeon General's report came out. It was a landmark report stating definitively not that that quitting smoking prevents cancer, but that quitting smoking after a cancer diagnosis has health outcomes. In cancer patients and survivors, the evidence is sufficient to infer a causal relationship. Those are really strong definitive words between cigarette smoking and adverse health outcomes, increased all-cause mortality, and increased risk of second primary cancers. There's building evidence that ideally we'll see in the next report in terms of cancer recurrence. So there's lots of national calls for action for this work. These have been adopters, I'd say, in the past 5 years. ASCO was one of the first ones identifying the importance as a quality indicator in tobacco treatment and cancer care. And this is a model that I put up to show you an article that we wrote, and it really illustrates nicely, I think, the lens through which Kelly's work is with patients with severe mental illness, and my work is to take, look at the patient prior to their cancer diagnosis, and continue all of those patient factors in consideration during their treatment. This is an article we wrote in The Oncologist looking at actually racial differences and disparities in tobacco use among Black adults. And we talked about the disparities in access to tobacco treatment and how that follows them with disparities in access to potentially cancer treatment and cancer outcomes. So we did a study, a trial. We've been very fortunate with support from the NCI. We called it Smoke-Free Support Study 1.0 now, and I'll tell you why later. That's the protocol if folks are interested in doing a deep dive into it. But it's basically a collaborative care model, which is very similar to the work that's being talked about today with patients with severe mental illness, patients with tobacco treatment. When a patient comes into the cancer center, treating tobacco treatment as if it was an important part of the patient's care. And we did a trial with two tobacco treatments. One was standard counseling, which is really the best care folks are getting out there who have cancer, who smoke. It was an adopted model from Sloan Kettering Cancer Center, who are collaborators, and a model that we had built here over the years through work, first with thoracic oncology and then throughout the cancer center, following patients' counseling and medication throughout their cancer treatment, more intensely at first as they're trying to quit smoking, and as Arthur can tell you, the extended support needed after you've quit during your cancer treatment through all of the vicissitudes of cancer treatment and being post-treatment. What we were looking at is across many different cancer types was effective. We have cost data, which is really important in all this research when you're looking at taking a factor in cancer treatment and trying to improve it. How much is it going to cost the cancer center? How does it work? And who does it work for? So the who works for is very important for us because we wanted to be able to offer this across the cancer center and with Kelly's influence, particularly for patients with severe mental illness. So we are able to really to have pretty expansive criteria. Someone just had to be willing to talk to a tobacco coach, didn't have to be willing to quit. English or Spanish speaking, it was bilingual phone access. And then the exclusion criteria, psychiatrically unstable, medically ineligible, or not getting their care. The psychiatrically unstable, unlike almost all cancer clinical trials with smoking, the majority of them, we didn't rule out patients we didn't use any screeners for depression or anything. We built a screener that Kelly helped us build, which just simply, basically, only exclude patients who had had a suicide attempt recently within the past year or who were actively psychotic. Everyone else could enroll in our trial. That was, even for me as a researcher, that wasn't how we had proposed it, but we were able to do it because I knew originally Bill Pearl had been here and he provided support for any questions, or Kelly did. We actually didn't have a lot of questions during the trial with these patients, so we ruled out patients. We asked patients and questions about symptoms, mania, hallucinations, delusional thinking, to see if there was any active psychosis, and then we documented their medications. So we were able to enroll patients from many stages, any type of smokers, and patients with any type of mental illness. So in research, that's really important because that means whatever our findings are, we can apply them across all cancer patients, not just patients with lung cancer, certain disease, or patients who are everyday really addicted smokers, or patients who don't have a mental illness history. And so basically what was very important is we had a tobacco coach, a counselor, who did collaborative medication selection. They went over a patient's history and selected and was able to, for all patients or patients with SMI, pick medications for smoking cessation that were offered free that might not have been otherwise offered to a patient or been too stigmatized to offer. The counselor reviewed the patient's medical record, assisted the patient in the collaborative decision making, and then assisted, most importantly, the oncologist in this decision. And this was a picture of the screener. For every medication, we went through this. So the counselor's there assisting and has the expertise to be able to make recommendations and share that with the patient and then the oncology team. These results are going to be presented next month at ASCO. The trial was a success. We found that significantly more people in the intervention treatment versus the control treatment, both groups got treatments, but were likely to quit. So the important thing, and the number I want to give you, is in the intervention group, 1 in 3 patients were able to quit smoking, and that's a conservative estimate because we had to get biochemical validation. Guess what? That was the same quit rate for patients in our trial who had SMI. So the trial participants, what we found is at every stage, we were able to keep the patients in the trial. 10% of the patients screened had a severe mental illness, 10% of eligible patients, so patients who were deemed eligible had a severe mental illness, and 10% of enrollees had a severe mental illness. So we were able to bring them into the trial. We had a very good response rate, so almost all the patients with SMI completed the trial. They were adherent to the counseling, which we found in the results we'll be presenting later at ASCO, that more counseling meant more likelihood of quitting. So patients with SMI were sticking with it, and their quit rates were the same as other patients. So our conclusions were that patients with SMI can be identified and enrolled, that optimizing psychiatric stability facilitates access to treatment, and then clinical initiatives really speak to these broader inclusion criteria for all patients in clinical trials. The happy outcomes for us is we were able to, with support for the Cancer Center, and we're looking to be able to sustain that support, start a service here, a clinical service across any patients in the MGH cancer centers. And guess what? We can include patients with SMI because we're confident that we can treat them. And then we're moving into, the NCI has just funded us to do a trial, a national trial with 15 community-based cancer centers, very diverse patient populations, cancer patients across the country. We're taking our treatment, we're gonna offer it virtually to patients, the counseling treatment, and we're relaxing our criteria using the same criteria for patients with SMI. One of the things I want to talk about in terms of outreach to vulnerable populations like patients with SMI are some virtual deliveries that we're using. We're delivering oncology clinicians' messages through videos, through VidScripts, and we're reaching out to patients. Our first trial was via telephone, but patients like to see their counselors, and so we're able to reach out nationally through HIPAA-protected video conferencing. So really important implementation in reaching out to vulnerable populations as well as this outreach. They don't have to come into the cancer center. So my final bridging points in this, and I want to add also that we also just started a study with lung cancer screening patients. Kelly and Efren Flores are involved in this, where there's a sub-study from the American Cancer Society where they're going to be working with patients with SMI to help get them into lung cancer screening. And we're going to be, in our trial, providing smoking cessation counseling to all patients across the partners' healthcare system who go for lung cancer screening, who are at elevated risk for lung cancer. And we're going to use the same relaxed criteria for patients with SMI. So to end, we had a paradigm shift. This work and the influence that all of you are doing really helped me think differently about who to include in my trial. There was no additional counseling needed, no additional counseling training or skills. Our counselors were able to reach out to patients with SMI to get them to successfully quit and connect with them in the same way patients with an absent history of SMI. We didn't have any psychiatric emergencies in the trial. We have parallel models, I think, to the work that's being proposed here, collaborative care, as Arthur had said, everyone being together. Is that this sustained contact and group work needs to be done with patients in terms of over time. Patients with SMI, patients who want to quit smoking, need brief contact but sustained over time. Not intense contact, but continued contact. And next steps is the enrollment engagement into the community. So we'll see how that work goes. Thank you.